Hello friends, myself Prasad Saka coming to you with a new topic in chemotherapy, that is anti-malarial drugs. Anti-malarial drugs are the drugs that are used to treat malaria. So, how the malaria is caused? Malaria is caused by protozoa Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. How the malaria is transmitted? Malaria is transmitted through bite of female anopheles mosquito, and because of malaria every year 2 million patients die. So let us see the pathophysiology of malaria and the life cycle of malarial protozoa. Coming to the malaria, the life cycle of Plasmodium, which includes of 7 stages. So here in the first stage, the parasite enters into the bloodstream through the bite of female anopheles mosquito. So that is called as blood meal. We call it as blood meal. So here we can see in the first step, it enters into the bloodstream. It enters into the bloodstream through the bite of female anopheles mosquito, and after 30 minutes it enters into the liver cells, hepatocytes, and in the hepatocytes they multiply and they produce one protozoa which will multiply to nearly 40 parasites or 40 protozoas within 5 to 6 days. So we call this particular stage as Seijont stage, and this Seijont means a collection of around 40 protozoans or 40 plasmodium protozoans in the liver cell, and this Seijont, when it ruptures, it releases merozoites. These merozoites enters into the erythrocytes. Erythrocytes means blood. These merozoites enters into the erythrocytes. Okay, so when they are present in the liver, we call it as hepatic cycle or liver cycle, and when it enters into the erythrocyte, we call it as erythrocytic cycle. So in human body there are two cycles. One is hepatic cycle and another one is erythrocytic cycle. So in the erythrocytic cycle, after its entry into the erythrocyte, it becomes trophozoite. Okay, so remember the stages. So if it enters into the liver, it is called as Seijont. When it moves out of the liver cell, we call it as merozoites, and when it enters into the erythrocyte, it become trophozoite. In liver it is Seijont, and in erythrocyte it is called as trophozoite. And trophozoite, when it gets multiplied, it becomes again Seijont. We call it as erythrocytic Seijont. And some of the trophozoites, they convert into gametocyte. Which enters into the sexual life cycle. So this is gametocyte, and now we will see the fate of each one. And the erythrocytic Seijont, what it will do? It will rupture and releases merozoites and enters into the erythrocyte again, and it attacks the erythrocyte, or it even again enters into the liver cell. It may infect both erythrocyte or hepatocyte. Okay, so that is erythrocytic cycle. So when the erythrocyte ruptures, it releases a chemical compound called as hemozoin, because of which we will get chills, and fever. And in the erythrocytic stage, this gametocyte enters into the, it divides into the, it divides to form macrogametocyte and microgametocyte. Micro means male gametocyte, macro means female gametocyte. These gametocytes, which will come into the peripheral blood circulation during night time. During night time, they'll come into the peripheral circulation. And when the female Anopheles mosquito bites, and from the blood, these gametocytes enters into the circulation of the mosquito. In mosquito, life cycle of protozoa, plasmodium in mosquito. In mosquito, these two gametes gets fertilized and forms into zygote. This zygote, which will form into ookinete. Ookinete is the fertilized plasmodium, and this ookinete, which is attached to the midgut wall. Okay, and within 8 to 15 days, it gets transformed into oocyst. Oocyst is a large cell which consists of large number of sporozoites, and this number is around 3000 merozoites. And these merozoites, which will released during the bite of female Anopheles mosquito to man, and these sporozoites enters into the human and infects the human, causes malaria. So this is the life cycle of the malarial parasite. Now we have to use antimalarial drugs to treat hepatocytones or erythrocytic cytones, and sometimes these merozoites or trophozoites, they enter into the tissues like GIT, brain, lungs, and liver. So we have to treat them. We have to kill those protozoans or plasmodium protozoans at different stages. So that is how we are going to deal with malaria. And coming to the classification of antimalarial drugs. Antimalarial drugs have been classified into 4 types. They are blood zoononticides, means these drugs will kill the malarial parasite present in the blood. Gametocidal drugs, means these drugs will kill the protozoans which are formed into microgametocyte and microgametocyte. And next one is casual prophylactic drugs, means it is used overall during all the stages and before the malaria occurrence of even. And next one is tissue zoononticides, when there is any trophozoites or merozoites that enters into the tissue cells, and we can kill by using these tissue zoononticides. Coming to the drugs that are present in blood zoononticides are quinine, chloroquine, amidoquine, mefloquine, atovaquine, halofentrin, chlorguanide, artesunate, artemether, and they are all fast acting. And proguanil, pyrimethamine, sulfonamides, tetracyclines are also used. Gametocidal drugs for all sorts of species, we have to use 45 mg single dose primaquine at rate of 45 mg single dose, whereas plasmodium vivax we have to use chloroquine, quinine, and mepacrine. And for casual prophylaxis, we have to use proguanil, pyrimethamine, and primaquine. And in tissue zoononticides, they destroys the hypnozoites, means which are at sleep stage or sedentary stage for a longer time. So for relapse, to prevent the relapse, we have to use primaquine and bulaquine. And for total eradication, we should use the combination of blood zoononticides and tissue zoononticides. And regarding to the drugs that treat malaria, in that main one is chloroquine, which is a 4-aminoquinoline anti-malarial agent which is used for the suppression of malaria. It is an excellent zoonoticide. Okay, and it does not prevent relapse. It cannot prevent relapse in Plasmodium vivax and Plasmodium ovale malariae. It has no effect on pre and exoerythrocytic phases of parasites. So it doesn't affect any sort of exoerythrocytic, means after the release from erythrocytes and before the erythrocytic stage. So it kills only erythrocytic cytons. And it also has an anti-inflammatory and local irritant properties. So mechanism of action, it influences the digestion of hemoglobin by malarial parasite cells. So it also interferes with the synthesis of nucleoproteins by parasites. And when it is used, indications of chloroquine, it is used in acute malaria, prophylaxis of malaria, rheumatoid arthritis, extraintestinal amoebiasis, giardiasis, discoid lupus erythematosus, infectious mononucleosis. And contraindications: eye disinfection, liver disease, severe hematological and GI diseases. During these conditions, we should not use chloroquine. Adverse effects, which includes nausea, epigastric distress, vomiting, itching, headache, and chronic therapy may cause loss of vision due to retinal damage. Corneal opacities may occur but are reversible. Skin rash, photosensitivity or photoallergy, myopathy, loss of hearing, and graying of hair are also adverse effects of chloroquine. And parenteral administration may lead to hypertension and cardiac depression. And coming to the dose, for adults, malaria, initially we should use 600 mg. After 6 hours, we should go for 300 mg. We need to titrate the drug, followed by 300 mg daily for 2 days. If at all it is injection, IM, intramuscular injection, we should give 10 ml. After 6 hours, 5 ml, followed by 5 ml daily for 2 days. And hepatic amoebiasis, chloroquine used at 300 mg twice daily for 2 days, followed by 150 mg twice daily for 2 to 3 days. In children's 10 mg per kg as and immediately we should give, followed by 5 mg per kg for 6 hours, for every 6 hours. Later, once in a day for 2 days. In children, if at all it is given in injections, 5 mg per kg for every 12 hours until there is a clinical response. Okay, and interactions, it is interacted with the antacids and reduces the absorption. And when it is reacted with paramethamine and sulfadoxine, it may cause Stevens-Johnson syndrome. So you should remember, when it is reacted with sulfadoxine or sulfonamides, it gives SJS, Stevens-Johnson syndrome. Quinacrine, it is increased with quinacrine. The toxicity of chloroquine is increased with quinacrine. And phenylbutazone, which predisposes to dermatitis. And next one is Arteether. This is developed by CDRL, Lucknow, Central Drug Research Laboratory, Lucknow. How it was developed? It is an ethyl ether derivative of dihydroartemisinin in sterile arachis oil. So this racemic mixture of alpha beta arteether, that is 70 ratio, which has greater solubility and stability than artemisinin, and also very cost effective. And its mechanism of action is rapid side-on-side action and brings out quick clinical improvement in falciparum malariae, and with low recurrence rate. It has some gametocidal action also, and it is used chloroquine resistant malaria, complicated falciparum malaria, and cerebral malaria. And its dose is 150 mg once daily intramuscular for 3 consecutive days. And next one is primaquine. Primaquine is an 8-amino quinoline and is a poor erythrocytic zygonticide but is highly effective against gametocytes and exoerythrocytic stages. Its mechanism of action is it disrupts the parasite's mitochondria and binds to native DNA, resulting in the inhibition of gametocytes and erythrocytic forms. Indication: radical cure of malaria caused by Plasmodium vivax or ovale. In adults, it is given at 15 mg daily for 14 days along with standard chloroquine therapy. In children, it should be given at 0.3 mg per kg for 24 hours of base as single dose daily for 14 days. And we should not overcome or exceed the recommended dose. And there should be test for G6PD deficiency. And contraindications: it causes SLE, systemic lupus erythematosus, rheumatoid arthritis and concurrent administration of hemolytic drugs. Adverse effects: it causes nausea, vomiting, weakness, abdominal pain and methemoglobinemia, hemolytic anemia in patients with G6PD deficiency, and passage of dark urine is an indication of hemolysis, and primaquine should be stopped when we observe dark urine. Leukopenia is seen rarely with larger dose. So by this we have completed anti-malarial drugs, and in the next class, in the next session, we will come with a new topic of chemotherapy. Thank you.